afternoon. In the context of Janani Suraksha Yojana, the NRHM has given us a service guarantee to provide emergency obstetric care in selected facilities in the country. And the chronic shortage of specialists for this is long known. So we try to study the initiatives to address shortage of specialists for provision of emergency obstetric care, EMOC in Maharashtra. So recently conducted a study. Myself and my colleague Dr. Bharat and Dr. Mistry from our team is here. Acknowledge their participation. The strategies that we studied are utilization of private sector, public-private partnerships, mostly through contracting in private specialists to provide these services. The other strategy that we looked at was task shifting, through which mostly medical officers are trained in EMOC and providing anesthesia for obstetric services. We tried to see how these particular strategies influence the size and distribution of providers for EMOC and how this influences related service uptake. We conducted a realistic inquiry into this situation using a mix of qualitative and quantitative methods. We looked at provisioning as well as the use of these services. We selected 3 districts in the state based on the Human Development Index and heterogeneity as well as geographic representation. We studied the provider side. We conducted a health facility survey in all the secondary and tertiary healthcare facilities, which are 44 in these 3 districts. We interviewed the civil surgeon, DHO, the program managers, block medical officers, medical superintendent, and medical officers. Also, we interviewed the obstetricians, anesthetists, both in public and private sector. We mapped the private specialists in these selected districts. To study the user side, we conducted a survey in 6 selected blocks in these 3 districts, which were the villages covered by 10 randomly selected sub-centers in each block. This survey identified women who had recently delivered and who are eligible for the JSY. In Maharashtra, JSY is applicable to women from BPL SC/ST communities and up to 2 live births. So we met 1,833 women, and of these who reported complications, we selected 120 women for interviews. These were selected on the basis of maximum variation sampling. Coming to our findings, excluding the 3 district hospitals, the 41 facilities at sub-district level there are 7 facilities of these that have both obstetrician and anesthetist. So remaining 34 facilities either lack obstetrician, anesthetist, or both. So hence, these 34 facilities form, that is 83% facilities, have a potential for contracting in or task shifting. Looking at these 18 places, 7 plus 18, 7 plus 11 is 18 facilities that have an obstetrician, we looked at performance. We chose to look at availability of cesarean section. When we consider CMOC, a comprehensive EMOC, we look at availability of cesarean section services. Hence, we chose to see how many cesarean sections were performed at these facilities. So, in a 6-month period from April to September 9, in these obstetricians in regular service, these are 18 facilities that have 25 obstetricians, and these 25 obstetricians performed 34 cesarean sections in a 6-month period. So, this is a gross underutilization of the people in service that we have. Also, 5 of these obstetricians are placed as facilities where there is no operation theatre, so they are not in a place where they can perform cesarean section. We can see that there are only 4 facilities that have been able to provide cesarean section in spite of having obstetricians, maybe for other reasons. Looking at distribution of obstetricians, as I said, we mapped the number of obstetricians in the private and public sector in these districts. So, there are district-wise variations, but findings translate to an availability of an obstetrician for one obstetrician for 217,000 population in the government sector, whereas if you look at the private sector, there's an obstetrician for 25,000 population. So, and also let me say, if we combine the two and look at the total number, we find one obstetrician for 23,000 population. So, there's really a question whether do we have a shortage compared to other states in India basically. We find that there are 8 times more obstetricians in the private sector in Maharashtra than in the public sector. Coming to the distribution of private obstetricians, we find that there are 260 obstetricians in these 3 districts. As we generally assume, most of them are located at the district headquarters in Amravati district, But if you look at the second district, second row in the second table, 75% of them are located at the sub-district level in a developed district of Maharashtra. So it really tells us where we have a potential. Looking at performance of people where there was contacting in done. Contacting was done at 7 of facilities. 34 facilities had a potential. 7 of them went for contacting in. Those are highlighted in yellow. And there were 4 facilities where medical officers were trained for conducting cesarean section, CMOC training or anesthesia training. And if you look at the number of sections performed in the same period, April to September 9, we could see that they hardly influenced the service output. There are 2 facilities, row 7 and 8, where the performance has been exceptional compared to others, and these point to leadership issues at those particular facilities. And also the facilities where task shifting was done, there was no cesarean section performed, basically because there was no skill mix. Where there was anesthesia, there was no obstetrician and vice versa. In this context, looking at availability of a private specialist for contacting in, we found that in these places, a private specialist was available for contacting in was more than 30 kilometers for 50% of the facilities. The 7 facilities where this was possible are those in the, those with the obstetrician or the specialist was less than 20 kilometers or very close, possibly in the same town. The other facilities have not gone for contacting in. Coming to our findings from the interviews with different respondents, people mentioned that contacting is not feasible in places where the facility, public facility, is not in the same town. So it's possible only if the private specialist is in the same town. Private providers were very concerned if they perform operative services, whether the post-operative care will be good enough in CHCs. Hence, these services have been mostly used for planned cases and not for emergencies, as was thought of. Private anesthetist says no complications have ever occurred at the PSC, at the periphery, sorry, at the CHC, because we select patients properly. We take only good, non-risky cases there. So no question of use in emergencies. Contacting doctors are generally young specialists who are yet to set their own practice and who want to set up a repute and a clientele base. And they come to CHCs only when they have no patients in the private sector, irrespective of the terms and conditions of contract. The administrators at district level mostly said that nobody is willing to come in the 1,500 rupees that JSY offers for contracting in, and we are paying from IPHS funds. What people said about task shifting, basically, administrators have no buy-in for task shifting. They do not believe that this builds enough skills or confidence for provision of these services. The issues of selection of medical officers, they're selected for this training 5 years after service when they have lost interest in clinical work and they're interested only in administrative work. They're posted at facilities where there's no infrastructure to provide these services, or there's no pair, there's no skill mix. Those people who are trainers for these trainings, they themselves are doubtful whether this training, whether the medical officers can perform those services independently in peripheral settings, though they do perform during training. The trained medical officers were concerned of medical legal issues when they provide these services, when they conduct a cesarean section or provide anesthesia, and the MBBS doctor is really worried whether he'll be caught in some medical legal issues. They demanded incentives, issues with their duration of training. They feel that it's very less to build enough skills, give them enough experience. Postings are not proper, and they demand refresher courses. And hence this explains why there was no cesarean section as facilities where these officers were posted. One of them says they send us for laparoscopy camps at the periphery, nothing else. That's what he uses his training for. This is additional load to me. What incentive I get is 25 rupees for a case of tubectomy. Other human resource issues that came up through our discussions with these respondents were, in Maharashtra, specialists do not have posting as specialists. They are posted as class 2 general duty medical officers and hence have to do all the general duties. They are paid much, much less than their counterparts in the medical education department. So there is a discrepancy, and that feeling is always there that the counterparts are paid almost double than they get in the public health department. Hmm. These respondents, obstetricians and nurses in the public service, relate their non-performance to they are frustrated with the system. One of them says the government does not even appreciate those who work. Actually, those who do not work make progress in the system. The salary is going to be the same whether I operate or not. And these people suggested better salaries, no general duties, more specialist work for them, opportunities for in-service specialization as solutions to this shortage. In our talk with private specialists, young specialists basically were attracted to job security in the government and better pay. One of them says, for people like me from middle class, government jobs are good. Only thing is there should be an assurance that will not be expelled. Otherwise, it is not possible for one to start a private practice after 35 years. Looking at the user side, of the 1,833 women we met who were eligible for JSY and had in the recent 1 year, 141 of them had a cesarean section, so 8%. Of course, there are variations amongst the 3 districts. You could see the row 2 where it's a tribal district and very, very low number of cesarean sections. Mostly there are no facilities. Of these cesarean sections, 141 cesarean sections, 57% were in the private hospitals. And looking at cesarean sections conducted at sub-district level, in the public sector, only 5% were at sub-district level, whereas in the private sector, 51% of these surgeries were at sub-district level, pointing to distribution of private specialists and availability of care at sub-district level, public and private sector. In this context, if the CSCs are non-functional, in case of performance of cesarean section, the next higher facility where they could refer a patient, government facility for cesarean section, is more than 50 kilometers for most of these CSCs. So this translates to a travel time of, minimum travel time of 2 hours in a rural context, where they could send a patient to a public facility. And this ranges from up to 150 kilometers in some places. In this context, where in case of unavailability in the public sector, women who availed care from the private sector, for 78% of them, the cost has been between 10 to 20,000 rupees for a cesarean section. To sum up, we find that there is a shortage of specialists in Maharashtra, but it is limited to the public sector. There are ample providers in the private sector. The obstetricians in the government hospitals are highly underutilized, especially for cesarean section or specialist services. Contacting in private specialist has limited feasibility and use in obstetric emergencies. Enabling conditions for the success of task shifting for EMOC have not been met, and availability of cesarean sections in public hospitals is quite scarce at sub-district level. So hence we recommend systems for performance measurement to improve utilization of government specialists. The specialist should be designated as specialist and posted accordingly, and the payments should be linked to performance. Contacting in should be considered as a short-term measure only and not for emergency services. Choice of task shifting should be revisited in context with overall high density of specialists. The question being, do we need to go for task shifting when there remain even enough opportunities to attract specialists to the public system when they are available in a state like Maharashtra? And enablers for task shifting should be met if it is to be undertaken, meaning training quality, licensing, posting, and incentives to providers. We acknowledge the financial support from the Makata Foundation and IIM Ahmedabad. Acknowledgements to our advisory group, Dr. Mavlankar, Dr. Doki from the Health System Resource Center, Dr. Yasudian from Mumbai, and our mentor, Dr. Mistry. Thank you all for patient listening.